And with that, I would like to briefly introduce Professor Antje Körner, who's a professor who holds a chair at the University of Leipzig. She's been working in the field for very long. She's a pediatric endocrinologist and has a lot of practical experience as well. Her work encompasses both national and international collaborations, and she's published in over 180 papers internationally. She has secured numerous grants and has received several awards for her work. And we are very pleased to have her with us and to now open this scene of this field and give that keynote lecture that is the introduction to this very exciting topic. So thank you very much for joining us, Antje, and the floor is yours.
Yeah, Annette, thank you very much for those really kind words. And I'm very happy to be here at this workshop. And also to have the opportunity to set the stage why we, from a pediatric perspective, think it's so important to really deal with these aspects. And so what I would like to discuss with you is how can we detect early glycemic or metabolic comorbidities in obesity in children. And so what I would briefly want to discuss with you is to show you that obesity is a disease which is really of high relevance in childhood. When do the first comorbidities of obesity emerge? Already in childhood? And actually, how are we set up for really detecting those glycemic comorbidities? Or maybe, you know, where are the problems and opportunity with that? So starting with the relevance of obesity in childhood, I think this is quite clear from a common sense perspective. But if we want to look into what is the frequency or the prevalence of the problem, we need some data. Maybe to start with, for those of you who may not be as familiar with working with children and how obesity is defined in children. We also, the definition is also based on the body mass index, and but of course we need to consider the development of the child. So we don't have fixed cutoffs for the BMI, but we do have those percentiles. And in Germany, for example, obesity is defined as a BMI above the 97 percentile, or sometimes you will see those standard deviation score, which is just an equal measure. Now, we all have the feeling that it has somehow changed over the last years or decades, and this is actually true. So if we want to see how this has changed, we can compare those percentiles, which are in the end a statistical measure. And this is done here for Central Germany and over a period of 20 years. And what you see is that the 3rd and the 50th centile haven't changed, but that the 97th centile, those are those red lines over here, has changed dramatically over those 20 years. So that means that not only the prevalence, but also the degree of childhood obesity has increased. And what you also see that this appears to start pretty early. It's actually in early childhood. But of course, to really understand and see when does it start, is there something like a vulnerable age for children to develop obesity, you need longitudinal data. And that we had available in Leipzig with this QuestNet registry, where we have longitudinal data of BMI in more than 50,000 children. Now, if we look at it, what is the risk if a child has obesity? What is the risk of it having obesity or being normal weight in adolescence? We did this kind of prospective analysis. So what this graph shows you that if you're a child, let's say with 2 years of age, what are your chances, and having obesity, what are your chances that you have obesity as an adolescent? And you see that in the first year of life, in infancy, the chances are 50-50. But already with 3 years of age, if you have overweight or obesity at that age, then the risk that the obesity is manifested is more than 90%. And also, if we want to really look into what is that kind of a vulnerable period, for that we looked into annual changes of the body mass index percentile. So to explain this graph to you, if this dot here at the 0 line means that a child rests on its percentile for BMI. On every dot above that line means additional weight gain, so on top of what you have already. And you clearly see that the early childhood between 2 to 3 and 6 years of age is the age where obviously the highest increase in BMI had occurred in those adolescents who have obesity. And this is actually something that has profound consequences. So even, well, let's say on a more philosophical level, and more than 15 years ago, there were already predictions that this increase in prevalence of obesity will affect our lives. Like Olshansky here stated that for the first time in human mankind, we have a period that the steady rise of increasing life expectancy may come to an end, and that the younger generation may live shorter and less healthier life than their parents. And then there was a subsequent study that actually showed that a little bit in more detail. These are still predictions, and they showed that if one could stop risk factors like smoking and a high BMI, that would result in an increased life expectancy of 5 years or even more if you look into quality of life related life expectancy. So that means, on the other hand, that if we don't achieve that the life expectancy is going to be reduced. And there are actually data that really support this, like this very nice study from Paul Franks in the population of Pima Indians. And what he did, he looked into the population and stratified them based on childhood BMI. So he stratified those in quartiles, those with the lowest BMI being the leanest, of course, and the highest being the heaviest, and then looked into the survival. And here are data shown for survival or mortality from endogenous cases. And you see that those who had been in the highest quartile of BMI during childhood, of those 10% already have been died by the age of 40. So it is really, in the end, a fatal disease. And not only because of this, but the major leading societies have acknowledged that obesity is a disease. It's actually a chronic disease, a complex disease that really requires lifelong care. Now, of course, why are we dealing with this disease? This is also because of the consequences. And we are all aware about the comorbidities of obesity, like diabetes, metabolic comorbidities, sleep apnea, cancer, cardiovascular morbidity, mortality, etc. And these are actually emerging already in childhood. Of course, we don't see, or we don't see children with a manifest heart attack, but we will see the first preclinical evidence for that. Just to give you some examples before I go more into detail on the metabolic stuff, in children with obesity, we see alterations in the growth of the children. So they are taller during childhood, but then there's a regression in puberty. If we look into cardiovascular function in more detail, like vascular function based on endothelial function or also on cardiac remodeling, then we do see that there are first differences in those children with obesity. And we also have children with an increased prevalence of liver steatosis, which is also a predictor of developing further metabolic complication. But of course, what we are here in this workshop most interested is the metabolic side of the comorbidities of obesity. in children. Now, what I want to show you here for a start is that the prevalence of diabetes is increasing overall. And this is data from the Center of Disease Control. And you see that it's particularly type 2 diabetes that is increasing in prevalence. And that again has a consequence which we as pediatricians and as pediatric endocrinologists and diabetologists may not be even as aware of, is that type 2 diabetes is at least as, if not more, lethal than type 1 diabetes. Now in this study, they, for example, compared the survival or the mortality on the other side in patients with type 1 or type 2 diabetes, if that manifested at young age, and you see that type 2 diabetes is more fatal than type 1 diabetes. Now, why are we discussing this in this workshop? Is that we want to do something about it. And actually, the other side is that there is a window of opportunity. So here again, you see in this study that if children have obesity and persistent weight gain, they have a much higher prevalence of comorbidity in adulthood. However, if we are, or if we would be successful to reduce that weight gain and to normalize the body weight, then we can actually reduce the risk burden. So there is a window of opportunity in this population. And this is also further supported by this meta-analysis covering some of the biggest epidemiological populational studies, again showing that if childhood obesity persists into adulthood, then there's an increased risk for cardiometabolic disease. However, if childhood obesity reverses and your normal weight as an adult, then we actually have the possibility to really reduce that risk burden coming with childhood obesity. So it is important to really to care about it and to treat it, but also to prevent it. Besides treatment and prevention, we also need to detect those children who are at higher risk. And what are the means that we have available clinically? So these are the criteria for the definition of diabetes and prediabetes. And you see they are based on actually on 3 parameters more or less. It's 2-hour plasma glucose, it's fasting plasma glucose, and it's HbA1c. And there are cutoffs defining normal ranges, prediabetes and diabetes. These are rather old. They're, they have been used for decades, but of course they do not entirely reflect the progressive insulin resistance and hyperinsulinemia in children with obesity. Just a short side note, of course, what we need to consider in children is that they develop, and during development there are phases where there are metabolic changes, particularly in puberty, which is a phase in development where physiological insulin resistance occurs here. So these are clamp studies, and this is a parameter of insulin sensitivity. So if it goes lower, then the insulin sensitivity is lower, meaning the resistance is higher. And these are the pubertal stages that you assess clinical. So 1 is before puberty, 5 is adolescent or adult development. And you see during the pubertal development, there's a decline in insulin sensitivity. However, what you also see that no matter at what pubertal stage you are, across all pubertal stages, the insulin sensitivity declines with an increasing body mass index. And that effect is actually much stronger than this pubertal insulin resistance. Now, in the slide before, I have showed you the criteria that we can apply based on the current guidelines. And if we look into a registry, this is a registry of Germany on children with obesity, and looked into the prevalence of impaired glucose metabolism defined by impaired fasting glucose, impaired glucose tolerance, or type 2 diabetes. And applying those, we see that 12% of the patients have some kind of dysglycemia. However, when you look into how is that related to the body mass index, these are the correlation coefficients, you see, it's not really great. And actually, if you look more detailed into, for example, the insulin response for a glucose stimulation, then you see that in children with obesity, the insulin response is doubled. So the body needs to secrete twice as insulin to try to keep the or to respond to those glucose challenges. So the question really is, do we have the right parameters? If we do apply those parameters and just repeat this oral glucose tolerance test half a year or a year later, then you see that based on these 2-hour blood glucose, it's rather poor in reproducibility. So what you see here is the classification of the glucose metabolism being normal, or with impaired fasting glucose, or impaired glucose tolerance, or diabetes. And then at the follow-up assessment doing the same test, then you see that even in those children who have been diagnosed type 2 diabetes, about 70% of those have a normal OGTT, and they haven't been treated with pharmacological medications or a very severe intervention. So using those parameters, the reproducibility is rather poor. And there are other studies supporting this, like, for example, this year, you see there are fasting indices as well as OGTT, or glucose test-derived indices, and you see that the correlation with the insulin sensitivity for those fasting indices is in general lower, particularly if you just use glucose and insulin. It does get better if you relate the insulin response to the glucose level. But you also see that the OGTT-derived indices, particularly those who are reflective of insulin sensitivity and who relate the insulin response to the glucose levels, may perform better. But we do not have any parameters or cutoffs for that. And this is what I think, or what we feel is important to have. So, of course, we need to consider the puberty, as I said before. So that's why we looked into the insulin sensitivity Matsuda index, which is one of those OGTT-derived indices across the age from early childhood to young adulthood. And you see several things in this slide. You see that decline in puberty, and actually the rise in sensitivity occurs later than we may have thought before. But I think even more importantly, you see that the insulin sensitivity is already impaired at a very young age. So you see here at 6-7 years of age. So this is not that, you know, obesity had been going on for 20 years, but you see that there's obviously something going on very early. Now, as we have this normal weight collective, we developed reference ranges for several of those OGTT-derived indices, like the Matsuda indices. And then if we apply those reference ranges and look into what is the prevalence of impaired insulin sensitivity in children with obesity, which are the blue ones, then you see that 50 to almost 2/3 of the children adolescents with obesity already have impaired insulin resistance. And you see that those numbers are much higher than the 12% that I showed you previously. And then, of course, we need to know, okay, what is the diagnostic value to related to existing dysglycemia? And for comparison, I put in the fasting plasma glucose and the 2-hour plasma glucose. And you see that OGTT-derived values perform better. And they are also better in predicting future glycemic failure. So here it is shown for the insulin sensitivity index Matsuda, and you clearly see that those who have impaired insulin sensitivity, that they have a much higher risk of developing dysglycemia much earlier. And just for comparison, the fasting plasma glucose, you see that it's not really possible to discriminate those children at risk. So those references could be used really to better stratify for risk for developing glucose deterioration. And this would really be a short, but the main message, what I want you to take out from that talk, in my opinion, is that we need to acknowledge that obesity is a chronic disease that can emerge in childhood. And if it does emerge in childhood, it's going to persist in most of the cases. What it's also important to know that the comorbidities of obesity develop early in childhood, and we should think that we need better diagnostic and predictive parameters to identify those children at highest risk. Of course, I want to thank all of my team and my collaborators in Leipzig and elsewhere, and the support by the grants, and would like to share with you our vision. What we really need to think, what we need to address is how can we identify those children at risk for progressive metabolic deterioration? Can we identify targetable factors so that we could be really in the position to prevent those severe comorbidity? And with that, thank you very much.
Thank you very much, Antje, for that very nice overview, particularly on the childhood obesity and all the questions that we have surrounding this. So if we do have time for a couple of questions, because you did not take the entire time, so I'm inviting everybody to either raise their hand or to write a question in the chat. Maybe I can start with a question. Gathering from what you just proposed, do you think it is necessary at all to worry about the dietary means of increasing or decreasing postprandial glycemia, or would it only be necessary to prevent or treat obesity, and everything else would then come off as a benefit spin-off?
Very difficult questions. I think actually both is true. Of course, if we can reduce obesity, preferably by preventing obesity really to develop, of course that would beneficially affect the burden of obesity, like for comorbidities. But I think also that in the end, where the field is moving to is to acknowledge that there are differences between the people, between the children, also in the metabolic setup. So there may be subpopulations that are particularly vulnerable and to develop those metabolic or other comorbidity early, and those we need to detect. And likewise, I think that there will always also be differences in the, or subphenotypes in the response, for example, to glycemic loads that might be handled by some subgroups better than by others. So if we will be able in the future to really to detect those children at risk and then go a step further and really maybe stratify, what might be the best intervention or prevention for certain metabolic setup, that would probably the way to go. Probably it will not help to just entirely focus on one factors and apply that to the whole population.
Mm-hmm. Any other questions? Yes, I do see one from Ute Alexy. Do you have data on fatness on how fatness interacts with fitness in terms of the metabolic risk? Diabetes or insulin resistance?
Fatness. So you mean body fat content or? Well, we don't have data ourselves, but there are studies published, well, a few years ago, also very, very, very nice studies that, for example, showed that if you, for example, perform a lifestyle intervention, particularly in children or adolescents, I don't remember quite exactly, then that you see beneficial effects on the metabolic side, even if you don't see those effects on the body mass index. So that means two things, or might be a combination of two things. One is that, of course, BMI is maybe not, or is not the ideal parameter really to assess body composition. And the other thing is that independent of that parameter, that if we do an intervention, particularly if we increase exercise, then we can beneficially affect insulin sensitivity, even if we don't see yet the effects on the body mass index, for example.
Mm-hmm. Sophie, you wanted to ask another question?
Yes, if we have time. First of all, thank you very much for this very interesting talk. Regarding the markers, you mentioned that the combination of insulin and glycemic response is better than just one or the other. But do you have an idea of even other types of markers, potentially even regarding inflammatory aspect, or even other ones, to try to identify the most at-risk children with obesity compared regarding adulthood?
Mm-hmm. That's a very good question and a very good idea. So far, it hasn't been, established on broad scientific evidence, particularly not for children. For adults, there are very good studies out there who actually go in deeper into the field of defining types and subtypes of diabetes by doing clustering based on several parameters, and those go beyond just insulin glucose. They incorporate also anthropometric parameters, other metabolic parameters, and also inflammation. And that has also been done for prediabetes. I think the field of identifying biomarkers, for example, to predict the risk of future dysglycemia is actually very, very active, and there have been biomarkers suggested, but as far as I am aware, or I would say it's not just a single biomarker and say, okay, yeah, that's the one who is telling us what's going to happen. Also, that might not be only biomarkers, but other comorbidities that develop. For example, we have looked into if there is already a steatosis of the liver existing, then we see that in those children, they develop glycemic failure earlier than those who haven't the steatosis. So I think it will be not a single marker or biomarker, but I think we will have kind of risk profiles consisting of several markers. Yes, I do.
We have two more questions. I think we can just briefly squeeze in the answers. And one is from our speaker that's going to speak later on, maybe a rather off-topic question, but what our best treatment option for childhood obesity? Is bariatric surgery seen as such a strategy? Could you just briefly answer that?
That's also a very good question. Well, I think we are all aware how effective, or better to say, how we're not really effective in preventing and treating childhood obesity. And bariatric surgery, not in children, but in adolescents, is, as in adults, the way which is most effective in reducing body weight. I think this is very interesting for several parts, because there was a study by Tom Inch just last year or 2 years ago, and he compared the effect of bariatric surgery between adolescents and adults. So both groups achieved the same degree of weight loss, but for example, the remission rates for diabetes as well as hypertension were much better in the adolescents compared to the adults. So this again points to that window of opportunity. Of course, bariatric surgery is not something that we can apply to, the entire population of children with obesity. It's not scalable. It's invasive. It comes with side effects. So this is, clearly kind of a last option. What is on the horizon now is for those who are at higher risk, that we will have pharmacological treatment options. And actually, those pharmacological treatment options, they are based on the understanding how bariatric surgery works. So bariatric surgery does not work by just reducing how much energy or how much food is consumed, but it works by affecting the incretins that are released from the intestine, because those incretins, like glucagon, like peptide, they increase and they have an effect on the insulin secretion as well as on appetite and food intake. And so now there's the first of those compounds being approved, I think just last month, for children and adolescents for the treatment of obesity and diabetes. But as I said, it needs to be a complex design, and it must be incorporated in a multimodal approach that's based on, of course, lifestyle intervention. But in addition, in severe cases and who are at increased risk, we will have further options.
Yeah. Well, there, of course, are people who are saying a low GI diet is working in a similar way, but maybe that's something that we can discuss on later on. One final question goes towards, when we're talking about vulnerable windows, is weight management of young children really a critical window to support? And I think I'd like to go along with that too, that we do really say that obesity shouldn't be diagnosed until the age of 2, because we know that it can revert, and that maybe weight gain at that time does not necessarily lead into obesity, whereas you've shown that those who are obese in adolescence have experienced their weight gain very early. But if we do look at all the children that are gaining extremely in those first years of life, then are we perhaps being overly cautiously and perhaps causing panic if we would address that? Maybe you can put that in perspective.
Yeah, well, I would strongly advocate to be very sensible to that in a way that we need to be aware that it's not just innocent puppy fat that's gonna vanish, because in most of the cases it will not. As I show you, I mean, these are data based on more than 50,000 children. There are other studies showing similar things. So in the first year of life, okay, the chances are 50-50, but then already it really, the risk increases if the overweight persists. So I'm not advocating kind of a weight reduction or severe low-calorie diet or something like that, but I think we need to be very sensible to install those lifestyle management and education very early at this age already. And also, I think the other side of the window of opportunity, that this age of 3 to 6 years, it's also an age where a lot of development occurs in terms of formation of habits. So that's also a window where we can really maybe effectively address future habits that are then sustained into adolescence and adulthood. So yes, the answer is I would be very sensible and would address that aspect and not neglect it.
Okay. I'm afraid we have to go on now. Thank you very much. And I know there are more questions, and I hope to divert them to the breakout sessions, and that we can continue this interesting discussion later on with. So